Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which you may find very handy in your line of duty. So I welcome you all to part 115 of our pharmacotherapy MCQ series, measuring in infectious diseases. Welcome. And our first question reads, your hepatologist decides to treat TKK, a middle-aged hepatitis C patient, using telaprevir in combination with PEG interferon alpha and ribavirin. My question to you is, which of the special dose administration statements listed below is correct in relation to telaprevir? Is it true that it should be taken with a meal that has limited or no fat content? Or should you encourage patients to take it with fatty meals? Or should it be taken with acidic beverages such as orange juice? Or should it be taken on an empty stomach with a full glass of water? I'll give you 10 seconds to choose the correct answer. I would counsel such patients to take it with fatty meals. Remember, telaprevir, marketed as Incivec, is a protease inhibitor that is indicated in the treatment of chronic hepatitis C, the genotype 1 to be specific. It has a very specific dosing instruction if we are to improve its bioavailability. And it is recommended that telaprevir be taken with meals containing fats, especially a standard fatty meal which contains about 20 grams of fat. Now this increases the bioavailability of telaprevir by about 237%. Now a low fat meal, for example 3.6 grams of fat, and a high fat meal of around 56 grams of fat, it both increase the bioavailability by 170% and 330% respectively. Let's move to the next question, please. And it reads, which of the following is the theoretical interaction when dexamethasone is administered prior to vancomycin during the treatment of meningitis? Is it A, there is decreased absorption of dexamethasone into the central nervous system? Is it B, there is increased absorption of dexamethasone into the central nervous system? Or is it C, there is decreased absorption of vancomycin into the CNS? Or is it D, there is increased absorption of vancomycin into the central nervous system? I'll give you 10 seconds to choose the correct answer. So there is decreased absorption of vancomycin into the central nervous system. Remember, inflamed meninges or inflammation of the meninges, increases penetration of vancomycin into the central nervous system, while the administration of dexamethasone decreases inflammation and may impair the ability of vancomycin to penetrate into the central nervous system. However, this shouldn't prevent the administration of dexamethasone to appropriate patients, but it should make the clinicians vigilant to ensure appropriate pharmacokinetic dosing of vancomycin. Now, the benefits of dexamethasone administration in bacterial meningitis is the reduction of neurological sequelae. Now, it's well known that less hearing loss occurs in children with H. influenza meningitis if dexamethasone is administered. There is also decreased mortality in adults with strep pneumomeningitis when they receive dexamethasone. I would like to remind you that dexamethasone may decrease the penetration of vancomycin and cause delays in sterilization of the CSF of strep pneumomeningitis. Now, the clinical impact of this isn't fully known, especially given the known outcomes that have been published. So just remember that dexamethasone should ideally be administered 10 to 20 minutes before antibiotics, or you can even administer them at the same time. Let's move to the next slide, please. And the next question reads, Mr. GPL, a middle-aged male patient, was treated for native vertebral osteomyelitis NVO and discharged at your hospital. 1 month later, he presents for a follow-up visit to assess the response. My question to you is, which of the following should the clinical team assess at today's visit, now that this gentleman has come for a review? Should it be MRI or CT scan? Should it be bone radiography using an X-ray? Should they have a look at CRP, or should it be ESR? I'll give you 10 seconds to choose the correct answer. The clinical team should assess an MRI or a CT scan, CRP, and even ESR. Remember, unchanged or increasing values of markers of systemic inflammation such as ESR or CRP after 4 weeks of treatment should increase suspicion of treatment failure. So it would be very critical to look at those. Then patients with persistent or progressive pain and systemic symptoms of infection, and even undrained or partially drained large epidural abscess or persistently elevated systemic inflammatory markers may be at a risk for treatment failure. And I would just like to add that CT scan is only recommended when MRI isn't feasible, and the use of MRI is preferred in this cohort of patients. Let's move to the next question, please. And it reads, Mrs. PMG, a 40-year-old female patient, presents to your chest clinic with pneumonia. She has a past medical history of type 1 diabetes mellitus, and she has an insulin pump to manage her diabetes. She also takes Yasmin for contraception. She tells the clinician she's allergic to morphine, and the last time it was injected, she experienced some itching. So my question to you is, which of the therapeutic options listed below would be the most appropriate for the management of Mrs. PMG's pneumonia? Would you settle for doxycycline, or would you use levofloxacin, or would you recommend coamoxiclav augmentin, or would you settle for azithromycin? I'll give you 10 seconds to choose the correct answer. I would settle for levofloxacin. Remember, this lady PMG has diabetes mellitus type 1 DM, which is a risk factor for drug-resistant Streptococcus pneumoniae. Therefore, in my opinion, doxycycline isn't appropriate for this lady. And then coamoxiclav monotherapy isn't appropriate due to lack of coverage for the atypical pathogens such as Mycoplasma, Legionella, and those are often the most common causes of walking pneumonia. Then azithromycin should be combined with a beta-lactam in patients with the risks of drug-resistant strep pneumo. Thus, when you use it alone, it would be suboptimal. If it's used in the management of PMGs and pneumonia, I would consider that suboptimal. Now, levofloxacin is the best option for PMG since no additional information is provided, and she is on an oral contraceptive, so I would assume she is not pregnant, which would normally be a contraindication for fluoroquinolone use. And at the same time, it does cover the atypical bacteria. So I would opt to use it in this particular scenario. Let's move to the next question, please. And it reads, which of the mechanisms of action listed below doesn't apply to oritavancin marketed as Obactive? Is it disrupts bacterial cell membrane integrity, or it binds to the peptide binding bridges of cell wall, or it binds to dihydrofolate reductase, or it binds to the stem peptide of peptidoglycan precursor? I'll give you 10 seconds to choose the correct answer. C is the correct answer. That's not a mechanism of action of oritavancin. Remember, oritavancin, marketed as Obactive, is a lipoglycopeptide antibacterial agent that is indicated in the treatment of adult patients with acute bacterial skin and skin structure infections, which we abbreviate as ABSSSIs, caused by or suspected to be caused by susceptible isolates of predominantly gram-positive microorganisms, and it is administered IV intravenously. It has three mechanisms of action, the first one being the inhibition of transglycosylation or polymerization. It is a step in the cell wall synthesis which happens by adding to the stem peptide of peptidoglycan precursors. It also inhibits transpeptidation, that is the cross-linking step of the cell wall biosynthesis by adding to the peptide bridging segment of the cell wall. Then it also does disruption of bacterial cell membrane integrity, which leads to depolarization, permeabilization, and even cell death. Now, these multiple mechanisms contribute to the concentration-dependent bactericidal activity of this medication called oritavancin. Let's move to the next question, please. And it reads, Mrs. STM, a 74-year-old female patient, presents to your accident and emergency department. She has an intra-abdominal infection, and she has an Apache score of 18, and the clinical team initiates her on fluids and norepinephrine before transferring her to the medical intensive care unit. Prior to admission, her meds were amiodarone, levothyroxine, warfarin, metoprolol, and aspirin. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. STM now? Would you choose to treat her with tigecycline, doripenem, cefoxitin, or moxifloxacin? I'll give you 10 seconds to choose the correct answer. I would opt to treat this patient with doripenem. Remember, cefoxitin, moxifloxacin, and tigecycline are only acceptable options for mild to moderate intra-abdominal infections. Now, we are told in the text that STM's Apache score falls in that range that is equal to or above 15. If I remember well, she scored 18. So she meets that criteria of being above or equal to 18, so she's considered to have a high severity infection, which is best treated with doripenem, marketed as Doribex. And note the other three. Let's move to the next question, please. And it reads, multiple risk factors may put an oncology patient at a risk of infection. So my question to you is, which of the following is a risk factor for infection in oncology patients with febrile neutropenia? Is it intact cellular immunity and rate of neutrophil rise? Or is it duration of neutropenia and rate of neutrophil rise? Or is it duration of neutropenia and destruction of protective barrier? Or is it intact cellular immunity and destruction of protective barrier? I'll give you 10 seconds to choose the correct answer. Duration of neutropenia and destruction of protective barrier would be the correct option. Now, in general, patients with neutropenia are at an increased risk of infection due to impaired immunity. In addition, destruction of the protective barrier, such as in patients with severe mucositis, for example, allows easy access for bacteria to enter the bloodstream, leading to bacteremia. Now, the longer the duration of neutropenia, the higher the risk of infection in such a patient. I would like to add that intact cellular immunity and quickly rising neutrophil counts may actually help prevent the patient from having an active infection. So that makes answer the other answers A, B, and D wrong. I would like to add that in patients with acute leukemias and lymphomas, monoclonal antibodies directed against cell receptors on the B and the T cell precursors, such as rituximab, can also increase the risk of infection. So be very careful in whom you administer rituximab, for example. Things would backfire on you. Let's move to the next question, please. And the next question reads, which of the clinical criteria listed below would meet possible infective endocarditis based on what we call the modified Duke's criteria? Is it 5 minor criteria? Is it 1 major criterion and 3 minor criteria? Or is it 1 major criterion and 1 minor criterion? Or is it 2 major criteria? I'll give you 10 seconds to choose the correct answer. So it is 1 major criterion and 1 minor criterion. Now, according to the modified Duke's diagnostic criteria, definite infective endocarditis is diagnosed when a patient has 2 major criteria, or if when the patient has 1 major criterion and 3 minor criteria, or when the patient has 5 minor criteria. Now, possible infective endocarditis corresponds to 1 major criterion and 1 minor criterion, or 3 minor criteria. The modified Duke's major criteria include the following: blood culture positive for infective endocarditis, typical microorganisms consistent with IE from 2 separate blood cultures, single positive blood culture for Coxiella burnetii, and even evidence of endocardial involvement, and an echocardiogram positive for IE. Then the minor criteria include, if I remember well, predisposing heart condition for, intravenous drug use, fever above 38 degrees centigrade, vascular phenomenon, major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, what we call the Janeway lesions, immunologic phenomena. And this immunologic phenomena involves glomerulonephritis, Osler nodes, growth spots, and rheumatoid factor, and even microbiological evidence, which may include a blood culture that is positive but doesn't meet the major criteria. You know, it's complex, it's tough, but I would advise you to read more about the Duke's criteria. Let's move to the next question, please. And the next question reads, Mr. MWC, a 57-year-old male cardiac patient, is scheduled for CABG in your operation room. He has no known drug or food allergies and currently takes lisinopril, salbutamol co-formulated with ipratropium, aspirin, and metoprolol. The MRSA rates in your operation room where Mr. MWC's surgery will be performed is 15%. And this gentleman, Mr. MWC, resides with his spouse, who happens to be an accountant, in their personal residence. So my question to you is, which of the following agents would be the most appropriate for Mr. MWC? Would it be vancomycin, cefazolin, linezolid, or nafcillin? I'll give you 10 seconds to choose the correct answer. So cefazolin would be the best option. Remember, cefazolin or Ancef is the preferred option for surgical prophylaxis for Mr. MWC's case, because he doesn't have any risk factor associated with MRSA carriage, and infection from this OR due to MRSA is quite low. Considering that percentage that we've been given the text above, I would just like to add that vancomycin would be the agent of choice if the concerns for MRSA were high, or if the patient had a severe penicillin allergy. So that makes A wrong. Then linezolid or Zyvox would be preserved for patients who are unable to receive vancomycin and who can't also receive cephalosporins. Let's move to the next question, please. And it reads, Mrs. JVK, a 52-year-old female patient with known chronic obstructive pulmonary disease, presents to your chest clinic with the day 1 signs and symptoms concerning for flu. A diagnostic test is done by your lab, and it reveals she has influenza B virus. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. JVK now? Would you opt to treat her with zanamivir, emantadine, oseltamivir, or rimantadine? I'll give you 10 seconds to choose the correct answer. I would comfortably treat her with oseltamivir. Now, only oseltamivir, marketed as Tamiflu, and zanamivir, marketed as Relenza Disc Hela, are recommended for influenza types A and B viral infections from that list of 4. I would like to caution you that zanamivir isn't recommended for patients with underlying airway disease such as asthma or COPD because its delivery into the body is done via inhalation, and it has the ability to increase the risks of bronchospasms, so it would worsen the state of such a patient. Let's move to the next question. The next question reads, Mr. DNT, a 46-year-old male patient with confirmed or known HIV infection, presents to your accident and emergency with suspected meningitis. The emergency medicine consultant on duty would like to initiate empiric treatment for cryptococcal meningitis. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. DNT now? Would it be amphotericin B, the liposomal form, dosed at 0.7 milligrams per kilo IV infused over 4 hours, together with 800 milligrams of fluconazole once daily? Or would it be amphotericin B deoxycholate at a dose of 0.7 milligrams per kilo IV infused over 4 hours, plus flucytosine dosed at 25 milligrams per kilo orally 4 times daily? Or would it be amphotericin B deoxycholate dosed at a dose of 5 milligrams per kilo IV infused over 4 hours, plus flucytosine dosed at 25 milligrams per kilo per day in 4 divided doses? Or would it be amphotericin B lipid complex dosed at 5 milligrams per kilo IV, plus flucytosine dosed at 25 milligrams per kilo IV 4 times daily? I'll give you 10 seconds to choose the correct answer. B would be the correct dose. I would administer amphotericin B deoxycholate at a dose of 0.7 milligrams per kilo IV over 4 hours and orally administer flucytosine at a dose of 25 milligrams per kilo orally 4 times daily. Now, amphotericin B lipid complex is preferred deoxycholate form for cryptococcal meningitis. However, the flucytosine route paired with it is incorrect. We don't give flucytosine IV. And I would like to emphasize that the only available formulation of flucytosine in the United States and in many other countries is the oral formulation, and that makes answer D wrong. Then I would like to add that the most appropriate dose and route for flucytosine administration for cryptococcal meningitis would be 25 milligrams per kilo orally 4 times daily. Now, amphotericin B, just for your information, binds to ergosterol on the fungal cell membrane, leading to cell wall disruption and cell death. Now, amphotericin B deoxycholate, the conventional form, is the most nephrotoxic form of all forms of amphotericin B. And just remember that flucytosine is converted to 5-fluorouracil in fungal cells through deamination via an enzyme that we call cytosine deaminase, and it binds to specific fungal cell walls, sparing mammalian cells, for example. Its toxicity can include bone marrow suppression and nephrotoxicity, so be very cautious when you use it in therapy. Then I would like to add that fluconazole is an alternative to flucytosine, but it is dosed much higher compared with the other indications where it's used. So it's usually 800 to 1200 milligrams IV as a single dose. Let's move to the next question, please. And the next question reads, which of the counts listed below corresponds to the amount of polymorphonuclear cells used to clinically diagnose spontaneous bacterial peritonitis, which we abbreviate as SBP, in ascites? Is it 1,000 cells per mm cubed? Is it 750 cells per mm cubed? Is it 250 cells per mm cubed? Or is it 500 cells per mm cubed? I'll give you 10 seconds to choose the correct answer. So 250 cells per mm cubed is the correct answer. Now the greatest sensitivity to SBP is reached at a cutoff value of 250 PMNs per mm cubed. Although the best specificity has been reported with a cutoff of 500 PMNs per mm cubed, note that PMN is polymorphonuclear neutrophils, which is suggested for the presence of bacterial infection. Since it's important not to miss a case of SBP, the most sensitive cutoff value is used so that we make sure we treat them if they have this condition. We want to avoid missing those patients that require treatment. Now, the most common bacterial causes of SBP include E. coli, Streptococcus species, and Klebsiella species. Now, while patients with cirrhosis are most common patient population that clinicians think of for getting SBP, it is important to recognize that it can also occur in other disease states where ascites can develop, such as heart failure, or what we call the Budd-Chiari syndrome, BUDD-CHIARI syndrome, and even in children with nephrosis, and even SLE. Now, mortality rates can be up to 70% in adults, and it's slightly lower in the pediatric patients, and it's high in the adults, especially if they have renal impairment. So you don't want to miss such a diagnosis. Be very, very careful and keen. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video has benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in subsequent videos. Thank you very much.